So thank you so much for taking your time to join this workshop. My name is Marion Otieno from Ryculture Health and Social Innovation. Today we are here to commemorate Neglected Tropical Disease Day, usually celebrated on the 30th of January. But aside from commemorating, we are also here to tackle the burden of NTDs, equip ourselves with skills that can help us eradicate in the eradication and addressing the burden of NTDs. Today we are joined by Dr. Nancy Kenyatta. She is a senior research scientist at KEMRI, Kenya Medical Research Institute. She holds a PhD in applied parasitology from the University of Nairobi. She has specialized in medical parasitology, entomology, and molecular biology. She has vast experience in epidemiological surveillance in lymphatic filariasis. So today we'll be focusing on 2 out of the neglected tropical diseases identified by WHO, that is lymphatic filariasis and visceral leishmaniasis, which will be tackled by Dr. David Odhiambo. So right about now, I'd like to welcome Dr. Nancy Kenyatta to give a presentation on the state of lymphatic filariasis in Kenya, the burden and gaps to access of care of the same. Karibu,
Yes.
Dr.
Good afternoon.
Good afternoon.
Am I audible enough?
Yes, you are.
You are able to see my slides?
Yes.
Okay. My name is, sorry, I'm in the last. Okay, my name is Dr. Nancy Kenyatta, as I have been introduced by Marion. I work for Kenya Medical Research Institute as a senior research scientist. And I'm happy today that I'm invited to give a talk, and of which we'll have discussion out of the talk. My talk is on lymphatic filariasis, the burden of NTDs in Africa and in Kenya. Mostly I will measure my talk in Kenya, and I will focus on lymphatic filariasis. As we all know that neglected tropical diseases are a group of diseases that infect humans, and they include schistosomiasis, lymphatic filariasis, leishmania, soil-transmitted helminths, onchocerciasis, and trachoma, among others, many others. And they affect more than 1.7 billion people worldwide. And mainly these diseases are found in Africa and affecting the poor of the poorest, mostly in the urban and rural areas. And these diseases are basically named as neglected because they receive very little attention in terms of funding, in terms of research, and also development. And they are less considered by the national government, by the medical and donor communities, despite affecting a number of people. For lymphatic filariasis, we know is a disease that is caused by nematode virial worms, which includes Ucheridium bancrofti, Brungia mealy, and Brungia timori. And Brungia Ucheridium bancrofti causes 90% of all LF infections. And this is a parasites are transmitted by mosquitoes of various species, including Anopheles, Culex, Aedes, and Mansonia species. The worms launch into the lymphatic system, and once they die and calcify, they cause blockage of the lymphatic system, which affects the flow of lymph, the normal flow of lymph. This disease is not fatal actually, but it causes high morbidity and leads to long-term permanent disability in its chronic stages. We know that this is the second leading cause of permanent disability, second to eye blindness. So the chronic stages can easily be prevented by early diagnosis and early treatment. For epidemiology, this LF is endemic in Sub-Saharan Africa, South Asia, subcontinents, Pacific Islands, and areas of America and Caribbean. Globally, the disease affects actually 68 million people, and 35 million people have microfilaria, with 19 million persons having hydrocele cases, and we have 14 million with lymphedemas or elephantiasis. In Kenya, just a minute. Okay, sorry. So in 2002, when the control programs began, we had 40% of all the LF infections in Sub-Saharan Africa, and with 46 million people with cases, including 432 million people who were at risk. This is Africa. So you can see the burden in Africa. And in 2018, the total estimated at-risk population requiring interventions in Africa was 341 million. So as we talk of the burden, you can see the burden is high. And actually for the signs and then diagnosis for this disease, lymphatic filariasis presents itself first as asymptomatic cases, where you have infections while someone is carrying microfilaria, but they are not showing any signs. Then we have symptomatic signs, where we have acute and chronic clinical stages. This disease leads to lymphedemas or swellings of the limbs, and also hydrocele, where we have the testicles or the male private parts filled with fluid. And for diagnosis, we have microscopy. We do microscopy where we do blood smears, either thick or thin blood smears. You do immunological antigen tests using the Vario test strips. We have molecular assays for DNA detection. And we also have X-rays and ultrasounds, where this one is mostly used for hydrocele cases. For the management and control, the global program to eliminate lymphatic filariasis was launched in 2000. And this was targeting to eliminate filariasis by 2020. And by 2020, majority of the countries were not able to, had not eliminated filariasis. So this was revised, and a new WHO roadmap targeting elimination by the year 2030 was drawn. This elimination was through two pillars, and one is to interrupt the transmission by mass drug administration to endemic countries for 5 years, for 5 to 6 years, which targets to cover around a minimum of 65 coverage of the population. And this is through administration of drugs, diethyl carbamazine citrate, albendazole, and ivermectin. These drugs are given in combination of either 2 drugs or 3 drugs, And the other pillar is through management, through morbidity management and disability prevention, through the care of the people who have mostly elephantiasis, the lymphoedemas, and also hydrocele cases, surgeries for the hydrocele cases. And also we have integrated vector management and management practices for the control of these diseases, which deals with the vector mosquitoes. What is the situation in Kenya? Where are we now? We know that mapping in Kenya was done in 1998, between 1998 and 1999. And only the coastal region was meeting the criteria for WHO to be considered as endemic. And in Kenya, the coastal region, we have 3.9 million people who are at risk of the infections. And the National Program for the Control of Lymphatic Filariasis in Kenya was launched in 2002, and the treatments actually began. And during that time, before the start of the treatments, the infection or the initial prevalence was very high. That was in most regions was ranging from 35% and below. And areas of Tana River in 2008, when before the start of MDS, because actually in Tana River, MDS started in 2008. The prevalence was around 26.4. And MDS, from 2003, when they actually began MDS in some sites, that is in Kilifi, the program was not consistent, or the annual drug administration was not taking place because of some logistics, some financial difficulties, or shortage of finances. And these MDS were being given with gaps of like 2 years, because the first one was given in 2003, then 2005, 2008, 2011. But as from 2017, this program started giving MDS actually annually. And before this, there was a study that was done by JEGA in 2015. And actually some of the infections in some counties had gone down to actually between 1.3 to less than 1.7. So the initial treatments actually brought the prevalence for the infection to low levels, to some low levels. Then as from 2015, as I have mentioned that before 2015, the administration or the mass drug administration was not regular. And after that, the program actually improved its quality and coverage. The program was able to cover a wide area and large population. But studies in 2018 showed that we still have some hotspots that needed more of rounds of MDS. And in the same year, 2018, a 3-drug regime was introduced. Initially, we were given 2 drug regimes, diethyl, carbamazine, and albendazole. But from 2018, there are some hotspots or some areas where we have started giving 3-drug regime. And with this 3-drug regime, that is the ivermectin, diethyl, carbamazine, and albendazole, it accelerates the elimination process. Actually, for the other countries which have used this drug, they have been able to eliminate filariasis within a shorter period of time. And also the second pillar where is the morbidity management and disability prevention interventions. In Kenya, this program has not really picked off well. It has initiated in some areas of Kwale, but it has not been well implemented, just like MDS. And this is this is an area. So this is an area where we need to focus our effort. So, what are the gaps that we have in NTDs? Some of the gaps fall across or cut across all the NTDs, not only LF. There is a knowledge gap where you find that in the community, in the health facilities, people are not understanding some of these diseases. They are not understanding the transmission. They are not understanding the management or even diagnosis. Actually, diagnosis is a very serious problem that we have. So that is why I'm saying lack of testing capacity in local health clinics. Actually, for LF, I have gone around in some endemic regions, but these services are not available in the clinics. We only offer these services during MDAs, which take place around the end of the year or once a year. And that is the only time that we have to do testing. So we lack the testing capacity, both the testing kits and the healthcare personnel. And then scarcity information of the burden of lymphatic filariasis morbidity. Actually, this is a silent disease, a hidden. Actually, it's called a hidden disease because of the nature of the disease progression from infection to actually manifestation of chronic stages. After infection, one takes like 10 to 20 years before a disease manifesting into chronic stages. So there are times people don't understand the burden because once the clinical stages set in, they are difficult to manage. Like the elephantiasis, they are not treatable. For hydrocele, hydrocelectomy or surgeries is done to drain the fluid. But in most cases, the morbidity due to lymphatic filariasis is not well understood by many of the people who are supposed to take care of these patients. Then we lack implementation structures or services in regard to the case management or lymphatic filariasis management. You find that there are no structured services for taking care of these patients. Like in the clinics, we need to have a clinic that is known that there are clinics in these endemic areas which take care of lymphoedemas or the hydrocele cases. So we lack those structural services. And also accessibility to endemic areas in the 100% geographical and 65 population coverage. So during MDAs, we are supposed to cover like 100%, or we are supposed to reach to all endemic areas. But we understand that, as we have mentioned, that the neglected tropical diseases affect the poor of the poorest. We find that accessibility to these regions or even to their homes, to the communities, it is not easy. They lack the roads, the facilities. So there is that hindrance of accessing the patients. Then the disease research and after control or elimination. Also, we are finding that this disease is most of them, they reoccur even after treatment. after elimination, they reoccur. And this is a problem. And one major problem is that during the pre-transmission assessment surveys, before we do the transmission assessment surveys, a process of elimination process, if cases are missed and we regard a disease eliminated, then there is always a possibility of research, a research of the infections. So there is need to do a very serious pre-transmission assessment surveys. Then how do we bridge these gaps? The NTDs have been included in Sustainable Development Goals. And this will accelerate the process of elimination. We have universal health coverage, which is a key for neglected tropical diseases control and elimination. Like in Kenya, the Minister of Health has allocated 2.4 billion in the financial year 2022-2023 towards the elimination of NTDs. And elephantiasis is actually taking 800 million for programs of enterocolectomy and elephantiasis care. And also a boost, we have a boost in research, capacity building, and development solutions, which will help overcome challenges like treatment, diagnostics, and management. So we can see that research has been very much received a lot of boost or attention. Not as earlier, the way we are seeing that neglected tropical diseases have been neglected. Of late, we are receiving a lot of funding, a lot of research for these neglected tropical diseases. And actually, I think very soon we will be removing some from the list of neglected tropical diseases. We know that treatment for these diseases, most of them, the treatments, we know they are not available. Some of them are toxic, like for leishmania. I don't want to talk about leishmania. Somebody else is talking about that. But we know the toxicity and the need for hospitalization. And we have mentioned that because these diseases occur in the poorest, they also lack the resources to access these treatments and also diagnostics and other management care. So if we bridge this gap of lack of these, make these treatments and diagnoses available to our people down there, then we will be able to accelerate the elimination process. And again, we need to enhance awareness, communication, and community engagement. For us to succeed in eliminating these NTDs, we need to inform our communities so that they can take up and also have these programs be taken up at the county levels. We need to make those people aware. Actually, in some areas, we find that people are totally in dark. They don't understand these diseases. They don't understand how they are transmitted, how they are treated. And some of them take these diseases as witchcraft or hereditary disease, like lymphatic filariasis. When you see somebody with hydrocele or those lymphedemas, they take them as witchcraft. So we need to enhance our awareness about these diseases to the community. And also we need to assist these people with the chronic stages. We assist them with alleviating sufferings from NTDs associated morbidity and disability. There are those conditions that you just need to take care of them. They need some psychosocial support. And then we need well-coordinated multi-sectorial actions where we need to combine a number of sectors like health, agriculture, these are national, TENEMA, and so many other sectors that when it comes to environment, or control of vectors, then they can also assist in prevention of these diseases. We need to integrate interventions for these diseases, especially these diseases that are controlled by mass drug administration. When they are combined, then it becomes cheaper, even to take the services to the communities, to educate them, and you find out we'll have killed more birds with one stone. Then we need to advocate more and have effective policy change by evidence-based research. As I have said that we are advancing in research. So this research, we need to help the policymakers change some policies for the management of diseases. And then what as the scientific world, or what advancement in tackling NTDs that the scientific world has managed to do? One, as mentioned earlier, I have said research. There is a lot of research and implementation of research. Then awareness. You go nowadays, when you go to those regions like where we work with the lymphatic varicose, now they understand. They understand that this disease is not witchcraft. It is not a family disease, as they call it. They now understand. So with the awareness and letting them to know just a few measures and control measures, then this is actually helping us in eliminating the disease. Then the health facilities. We know there is this Drugs for Neglected Disease initiative. We have some facilities in regions where with endemic areas of diseases, like mostly this one has really grown for elimination of or treatment or management of leishmaniasis. But it is not in all regions. So we also want to advocate that these services also needs to get to other facilities where the disease is endemic. And also for other diseases like lymphatic varicose, we are advocating that if the diagnostic kits can get to the local clinic, then it would be easy for early diagnosis and treatment. Also, we are talking about diagnostics capacity, that we have been able as scientists develop newer and effective diagnostics, either kits or diagnostics assays. And this really has improved in the management of the disease. We know, like there are diseases that there are areas where we face challenges with the diagnosis, especially when there are mutations with the parasites. They affect the diagnostic target, or the diagnostic target changes. And we have to keep on looking at our diagnosis. Earlier on, for example, with the lymphatic varicose, the antigen test that we were using was ICT, or immunochromatographic card test. And it grew some, it developed some cross. I was talking about diagnostic capacity, where I'm saying that scientific world is developing newer and effective diagnostic tools to enable us to do early diagnosis of these diseases. And I was giving an example of lymphatic varicose, where we were using earlier, we were using immunochromatographic card test. And with this card test, it developed some cross-reactivity, and it became insensitive. So you find that it was not giving the accurate results. And then we came up with the Viradio test kits, strip, Viradio test strip. So every other time we are working on this diagnostic capacity so that we don't miss infections, or we get even easier and cheaper ways of diagnosing these diseases. And also with the scientific research, we have treatment advancement. We understand that some of the treatment, especially for leishmaniasis, they were taking too long. Injections, very painful. But now the treatment, the treatment is becoming easier and taking lesser days. And even for the other diseases, a lot of research on treatment, on vaccines is being worked on. And then I want to recommend that there is a lot, I want to say that there is a lot that the scientists are doing on the bench, but we need to move this knowledge, or we need to move these services from the bench to the community where they are needed, or to the endemic areas. Because you find some of the diseases, they are still being referred to our labs, other than having these services on the ground. So this is my recommendation, that we need, and this needs funds, because you see that because of the process of research, there are times scientists work with the animals and they are not able to proceed to clinical trials, maybe due to lack of fundings. So the services that we have already gotten and the others that we are working on needs to be taken to the community. Sorry, I'm not able to move my slides. What has happened? Okay. Let me see. Then finally, I want to acknowledge the organizers of this workshop. I acknowledge Dr. Esther Kaduma, who was my PhD supervisor, is the one who has connected me to this workshop and requested me if I can give a talk. Then I want to acknowledge Cambridge, my institution, for allowing me to give a talk, and all the participants. And then we have, these are photos that I have taken from the field. And thank you. Marion, you can talk over.
Okay, thank you so much for that great presentation.
The land juicy. The regulated tropical diseases. Shit.
Sorry about that. Thank you so much for the great presentation. Now the floor is open for any questions from the participants. If you have any questions for Dr. Nancy, you can either raise your hand or just type them in the chat box. Any questions? Dr. Nancy, you can now stop sharing your screen. Okay. Thank you. Anyone with a question? So I think my question to you, Dr. Nancy, when you are talking about the progression of lymphatic filariasis from asymptomatic to symptomatic, then to the critical stage, in the symptomatic stages, what are the symptoms of lymphatic filariasis? Are there any other, apart from hydrocele and lymphodemas?
Yeah, there are other symptoms that affects even the lungs, because you see during the circulation, the worms sometimes get to the lungs, and you have some you have infections in the lungs, but the most common would be the hydrocele and the lymphodemas, or the swellings of limbs, not necessarily the legs, but the legs are the most common. You can have the hands, the breast, and another part. I think I have answered your question. Then for symptomatic, you can have, we have levels where we have like level 1, 2, 3, and 4. Like level 1, you'd have swellings which come and go, and those stages are treatable. But the moment you get to those chronic stages where the legs are fully swollen, then we can only manage the wounds. But for hydrocele, surgeries, hydrocelectomy is done, and one is relieved from the pain.
Okay. There's another question in the chat box. What is the current regimen for lymphatic filariasis in the hospital setting?
In the hospital settings,
yes,
the regime, currently we were trying the 3 regime, the ivermectin, albendazole, and ivermectin, diethyl carbamazine, and albendazole. But in most hospitals in the endemic areas, we don't have these regimes. Actually, we only get diethyl carbamazine during the mass drug administration. So they are not locally available in our hospitals. And this is an area that we need to look at if we really want to achieve the elimination process. But we need to educate our doctors out there. In cases, they get these cases, they are able to administer albendazoles and ivermectin, even if diethyl carbamazine is not available. And we mostly rely on donors. When we are out there to take MDS, we are relying on donors to provide for these drugs. But our county governments are actually taking up. And we hope that soon the regimes will get to our hospitals. Thank you.
Okay. Another question from me would be, what is the role of the youth in eradication of NTDs, particularly in the work that you do? Are there opportunities that youth can plug in and lend their voice or actions in a bid to eliminate lymphatic filariasis now, to be specific?
Okay, there is a lot that the youth can do. One, we've talked about advocating and policy change. The youth can have a voice in raising these concerns in our governments and in our other setups. The youth can assist with these local communications or communicating or the awareness to the public, to our doctors out there. And we also do, during MDS, we do door-to-door visits. That is a place where youth come hand in hand to assist with the distribution of drugs. And the research, they can get involved in research, the diagnosis, treatment, vaccines, development.
Okay.
I hope I have answered you.
Yes, you have. Maybe just to add, in your places of work,
yes,
are there opportunities presented to youth to be able to join in the fight against neglected tropical diseases generally?
Yeah, in our working place, we have internship for students that which are being placed by the government. So we integrate them in our day-to-day work, we involve them in our projects, and we deal with various NTDs. So they really get integrated in our systems. And also we have other research, we get other research grants from outside donors. We also engage students maybe on contracts basis to carry out the research.
Okay. Thank you so much, Dr. Nancy, for your presentation and for answering our questions. The next presenter will be Dr. David Odhiambo, who will be giving a case presentation on visceral leishmaniasis. That is one of the projects in Ryculture Health and Social Innovation. So I'd like to welcome you, Dr. David.
Thank you, Marion. Thank you, Dr. Nancy, actually, for the wonderful presentation. Became a series for me learning in terms of the work you're doing, and thank you for that.
Welcome.
So, yeah, and actually one of the key things that from that particular presentation that you've made, I'll be keen to see how we could engage as well, because I know most of these young people are keen to look at what opportunities and what possibilities are out there for them. And that is also one of the things we are trying to explore within Ryculture with regard to the Youth Voices Network. How do we engage young people in this research? How do we ensure that they're contributing to addressing some of the pressing healthcare challenges in the continent as we move forward? So on that note, then I'll switch to my presentation. Honestly, it was a very brief one, and this is some work that I did in 2020. So please let me know when you can see it. It's going to be a very brief presentation. It's 4 slides specifically that. So for this presentation, I'm basing on my internship experience, and that is the basis of what we started working on as Ryculture, and what are the next frontiers for the work that we can do with young people in managing neglected tropical diseases and actually shaping that conversation to the next phase. So on that account, then we need to ask yourself, what is leishmaniasis and how does it come about? So in this particular slide, basically giving a brief background, being that leishmaniasis is a parasitic infection caused by leishmania, which is transmitted by sandflies. In terms of the different forms, we have 3. That is Kala-Azar, the visceral leishmaniasis, we have cutaneous, and then we have the mucocutaneous, depending on the parts of the organ, the body that they're affecting. Visceral is internal body organs, including the liver. The cutaneous will be affecting the cutaneous surfaces, mucocutaneous, the membranes within your mouth and all that kind of stuff. So there are different 3 forms. And of these forms, they're dispersed in different regions. And the most critical, actually, the reason as to why I'm talking about it, is something that is affecting our local context. And that is in a Kenyan landscape, we are mostly affected by visceral leishmaniasis. And even in the presentation that was made by Dr. Nancy, you acknowledge that there's a critical component of VL, and most of the programmatic support has been coming in this area. So that is one of the key things we have to acknowledge as well. It's the burden of visceral leishmaniasis is substantially high in our region, in our country. Then on another note, we need to acknowledge it's a curable disease. So with the appropriate treatment, somebody will recover, but it still causes substantial morbidity, and actually some people die. And in this case, I lost a kid actually during that time when I was practicing at the facility. That was on 12th of February, 2020. And it wasn't a good experience, acknowledging that there are medications, but we're not able to save a life because of certain gaps and flaws in our healthcare system, which is critical for us to address. So majorly, the main challenges in that case we're looking at is in terms of low level of clinical suspicion by healthcare providers, delaying diagnosis, and therefore with delayed diagnosis, the treatment will also start at a later phase, which is a problem. So how do we challenge such? Then in terms of access to treatment, it's also very, very challenging. And when you talk about treatment being challenging, is because, as mentioned, the fact is visceral leishmaniasis is treated by injectable medications. So the first line of treatment, we are talking about sodium thioglutaminate and paromomycin. If we have complications, then we'll have to move to liposomal amphotericin. So these are injectable antibiotics that are used in management of leishmaniasis. If it's injection, it means if you are lucky to be in a region where the hospital closer to you has the medicines, you will have to be visiting the facility every single day to be treated, to receive your dose. Otherwise, you'll have to be transferred to a facility where the medicines are available, be admitted in that hospital, and after that, have to come back after you finish your course of treatment. And this is not a short course of treatment because the basic minimum is 17 days of injection. So that is 2.5, 3 weeks of treatment. So how sustainable is such kind of an intervention that has to be offered? Then a lack of inadequate information on the prevalence, the burden, and spatial distribution of the disease, with incidences reportedly majorly in arid and semi-arid areas. And you all understand when we talk about them as neglected tropical diseases, they are neglected because most people are not talking about them, and that is the reality of the situation. And why is it that most people are not talking about them? One, most people who are able to talk about global health challenges, diseases, and everything are able to talk about what they know. The first driver for us to talk and actually discuss a particular issue is because we know it exists. In the arid and semi-arid regions, one of the key bits is access to information is a challenge. We are dealing with socialization challenges where even some of these diseases would be considered curses, witchcraft, and whatever it is in the local communities. So in other words, the very locals will not be able to identify it as a disease that needs to be looked into. But this has changed over time because we have penetration in terms of education levels and all that, which is a good thing for us. So during that experience that I was at Kenyatta National Hospital, that was in 2020 during my internship, I dealt with 8 children who are suffering from visceral leishmaniasis from Mwingi Level 4 Hospital. And in that case, when they were coming to the hospital, one thing that we noted is over time, they had started management at that local facility. Either it was in a dispensary level 2 or level 3 facility, later to the level 4 before they were transferred to KNH. And in both cases, they were being managed for malaria or stomach upsets. The course of treatment was either coartem, or if not coartem, they were now being moved to start being managed on metronidazole flagyl because they were suspecting it's an GIT infection, which is wrong because now you're treating a condition that the person is not suffering from. It becomes a high for the patient. Then moving forward, the next phase, what we noted, that is the high disease burden in that particular region because it's kind of an isolated facility, that was the location. Then beyond the high disease burden and low clinical suspicion, another thing that was becoming a problem is these are diseases that we expect could be managed at a local community facility level, level 2, level 3, level 4. But now it's been transferred to Kenyatta as a tertiary training and research institution. What is the first thing that will happen? At Kenyatta, the first thing that the physicians were looking at, it's not leishmaniasis. For them, they're suspecting this might be either a hematological problem or it's kind of a cancer and all that. So therefore, we are investigating and doing lab works to confirm whether there's a cancer, there's a growth in the tissue, and generally being it's a liver problem, we're starting with biopsies and all that. So we are looking for a disease that is not the disease we should be looking for because we're expecting because of the complexity or the lack thereof, this disease would have been identified and diagnosed at a local community level, which means this patient might take more time in the facility than would be expected of them. So they take a week before the final test results come. Yet this is something that would have been tested by the rapid diagnostic kits on the first day of arrival. And that patient could be started on treatment to recover better. And one of the key things that we have to acknowledge as well, most of these diseases are diseases of poverty. And poor families are more affected in terms of, when you look at it in terms of prevention and protection, we're talking about use of most treated bed nets. Some of the families don't have them, but goodness is now currently these are being distributed generally. In the local communities, because of the arid and semi-arid conditions, sandflies are actually around those spaces, so that is a risk. Children are playing all over and everywhere. Nobody is doing environmental control and insecticide spraying, so the pests are still around in the environment. And those are gaps that we are seeing. So in terms of that, at that particular moment, some of the solutions that we are proposing to intervene were, one, can we map the local community regions so that we identify high-risk areas where we can now deliver intervention? That was the first thing. Because unless we identify that region, because in this case, we're talking about Mwingi, Kitui County, Kaseluni as the sub-county or the ward in that particular area. Can we get to the local community leader? With that local community leader, how do we work to support access to care for these people, even doing interventions with the clinicians in the local ground so that they don't treat malaria where there's no malaria. They have the diagnosis, all that. So that was a critical bit that we were looking at.
Hemolysis, elevated liver enzymes, and low platelet.
Yeah, so other than that, the other bit was now community sensitization on and facilitation of protective measures, i.e., can we provide these treated bed nets, insecticide repellents, then also offer advice so that the community understand that this is a medical condition, they need to respond and actually find a way to address it. Children are being sensitized to be coming back home earlier rather than staying late in the evening when the sandflies are now leaving their hibernation spots so that they can feed on the human subjects. So those are some of the things. Capacity building for local facilities that were key, vector control through environmental interventions. I remember when I was growing up in the local village in the community, we normally had the cattle, kind of, I would call it the stream where we used to take cattle to take water. And in that kind of an arrangement, we would have, let's say, after 2-3 months, there was a coordinated engagement with the local community elders. And anybody who had animals would go to the stream, do the cleaning, and actually clear up so that it could serve as a good reservoir for water. Having such kind of community engagement vector in the environmental interventions would be workable. Then finally, we need to ensure there's a reliable drug supply for diagnosed patients through the local unit. And that is a critical bit when you talk about management in terms of medicines. Most of the medicines for neglected tropical diseases are donor funded and donor supported. Currently, when you look at the Ministry of Health Neglected Tropical Diseases Department, Kenyatta National Hospital behind the scene. So what the kind of things that they do is they have reporting, and then with that reporting, the Ministry of Health would coordinate in terms of the numbers, and the WHO would facilitate the supplies through the development partner funded programs. So how do we make those work? So that is how the kind of approach that we're looking at. So living on that, then the question that we ask ourselves is, as a young person, what role can you play in managing actually and responding to the neglected tropical diseases burden that we're dealing with? From an African context and from a Kenyan perspective, we have to acknowledge that these problems are affecting us and are affecting our local communities. And therefore, it is our responsibility to do something about it. So what are we going to do about it? First things first, we need to be informed. Unless we know what the challenge is and what problem we are going to address, then we are not going to do anything about it. So we need to be informed as the first thing in terms of managing these particular diseases. So that is the first thing. How are we getting informed? Literacy levels and all that, we need to learn as much as we can. Then the next bit, other than being informed, is to identify which community am I coming from? What is my interest? Can I mobilize the local communities, or is it not possible at that particular moment? Once you are informed, you have the information and you know what can be done, what can't be done, and how do we do it better. So that is a very good starting point for you once you're informed to see what can we do, what can we address. And when you look at it in terms of the mapping of the region, because we need the epidemiological and the prevalence data to know where do we need to intervene. Beyond that, as young people, and one of the key things that I've acknowledged in terms of this engagement, most of our people are young people. Either they have health-related initiatives, or they're university students pursuing medical courses, or community health programs and development-related programs. So in that case, then you're able to mobilize your community. If you have the medical background, at least you're literate generally, you're able to understand, how do I engage with these people, and what kind of information can I share with them, and at what level? So that is good for you. As a medical student, generally with a medical background or biological sciences background, this is an opportunity to research. And when you talk about research, it can be the operational research, which is getting the problems where they are, what intervention can be implemented, and all how we can move forward in terms of addressing these challenges, the operational research perspective. But you're also capable of getting into the core research in terms of clinical lab works, so that you're able to do further studies and even establish medication and therapies that we need to address these particular challenges that are existing. If you have an interest in that, the organizations like Cambria Research working in those research, we have FIND, we have the drugs for neglected diseases, and even some of the biopharmaceutical companies are working towards promoting research in the NTDs department. So you need to be looking out for such opportunities, and in case you have an interest, you can also explore from our networks on which avenues would be suited for you within the Ryculture network, Youth Voices network. That is important. Then beyond that, then the other key thing that is critical, we're talking about ending neglected tropical diseases. These are affecting us within the healthcare sector. So the question we need to ask ourselves, what are the health systems pillars that are either failing or are unresponsive, that are causing us to suffer these consequences? One of the key things, we need leadership and governance, financing, and all that. As a young person, probably you're not making a decision on how much is going to be apportioned or assigned to management of neglected tropical diseases. But acknowledging the burden of neglected tropical diseases, knowing where the problem exists in your own local community, You can engage with the legislators and policymakers in the different public participation forums. And in those engagements, you can push on them to actually provide a budgetary allocation for the management of neglected tropical diseases, whichever particular disease you've identified that you need to focus on. In so doing, we'll have financing, and with the financing, we're able to buy the medication, we're able to manage the mapping and the capacity building of the local healthcare providers and the facilities to be able to offer care to the people who need them. That would be a contribution that you'd make as an individual in the policy and advocacy space. That is a good thing that we can all work on. Beyond that, then you can also form your local networks. And even when we're listening to some of the conversations and the training that we've had from Dr. Nancy, we know there's mass administration or drug administration in most of the neglected tropical diseases. And one key thing that normally happens when we're having these mass drug administrations, there's limited workforce. Because you can't close a whole clinic and go for a mass drug administration, or even the schools where they facilitate these activities. That case, they need young people who can support in drug administration. Can you explore partnership with such kind of organizations so that when they're going for this mass drug administration, you're part of the team delivering intervention, you are learning, you're exposing yourself, and you're networking with the people who are leading those particular programs. In so doing, we are taking local ownership and addressing the gaps. So what we can do in this particular slide, what I've just talked about it at high level, but the key thing was in terms of what are the challenges, what can we do? For early diagnosis and case management, there's low clinical suspicion. We need to be informed whether you are a healthcare worker so that you can actually point, chances are this is the issue. Low literacy, can you enlighten people? Can you educate them so that they know more about the disease? Then effective prompt treatment, we need access to essential medicine. The data about where the disease is, the burden of that disease will inform how much we are requesting for. And also advocating for policies, more finances, then we're able to buy those medicines when we need them and where we need them. Effective disease surveillance is critical in terms of getting that data and doing the intervention that we need to do. Environmental control, I talked about in terms of mobilizing local communities to work. Then finally, policy advocacy. And at this policy advocacy level, one thing that I just want to add here is the fact that we can do policy advocacy on a particular disease area, but we can also integrate it into current and emerging priority topics of discussion. When people are talking about sustainable development goals, there's no sustainable development when people are unwell. When a parent who is a hard worker in the country who can actually contribute to the economy is going to spend 17, 20 days in a hospital taking care of a child who is sick of visceral leishmaniasis. That is lost labor because of this disease and sickness. That is not growth in terms of development. So how do we link these? And if we are able to align our policy and advocacy priorities on the prevailing and current issues like sustainable development goals, universal healthcare coverage, what is the burden of, let's say, for example, current moment climate change in the burden of neglected tropical diseases? And that is a reality. We are talking about the current burden of visceral leishmaniasis is more on the arid and semi-arid. With climate change, we are actually expanding the zones that are going to fall within the arid and semi-arid areas. It means more people are going to be at risk of suffering from these diseases because the more we enlarge our arid and semi-arid land territories, the more conducive environment we are providing for the disease vectors, the sandflies. With the sandflies going into those regions, definitely we have children who are in those positions and people who are living there. They are at a risk of being infected. So how do we ensure that we ride on current challenges and current issues that need to be discussed, but at the same time, we are focused on what do we want addressed? How do we want it addressed? And how does it link into what is the priority area of discussion so that we move forward into the next frontiers? And in doing so, I think as young people, we'll be able to deliver more and we'll be able to drive these conversations towards eradication of neglected tropical diseases. Thank you so much for this. And I'm glad that you guys are part of the conversation. And I'm hoping we're able to drive the conversation moving forward beyond this webinar, but into the future where we have a healthy and prosperous population. Thank you, and back to you, Marion.
Thank you, Dr. David, for your presentation. Does anyone have a question for Dr. Odhiambo? Any questions? Okay. So there is a question, are there cases of patients with visceral leishmaniasis not responding to current regimen? And what are the interventions for patients with hepatosplenomegaly?
Okay. So in terms, those are 3 questions. Thank you for these great questions, Mohammed. So the first thing, how can we prevent as healthcare workers the misdiagnosis of NTDs to avoid complications? The starting point for this kind of misdiagnosis is, do we suspect? Because normally when a patient comes to your facility, the first thing that you do based on the patient history is differential diagnosis. And that differential diagnosis, you have to outline a list of probable conditions that might be affecting that person. So if you're coming from a region where one or any of the NTDs is prevalent, then it should fall within the differential that you're dealing with. That is the first thing. So does it fall within the differential that you have? And the best way we can do that is being enlightened and being more informed about the epidemiological patterns and disease prevalence in our regions of practice. If I'm in Nairobi, what diseases are more prevalent in Nairobi? Especially when we deal with it from the infectious disease standpoint before even going to the non-communicable diseases. That is a good starting point. Then with that, we're able to address. Then we get to learn more about the disease so that we know how to manage it, so that makes it easier. Then beyond the clinical suspicion and differential diagnosis and all that, at the point of treatment, for you to diagnose, you need the kits. Do we have the kits in the local facilities? Are we requesting for them or we're not requesting? Because even at a clinic, if I'm not requesting for rapid diagnostic kit, the R39 kit, then there's no likelihood that the government will provide them to me or any stakeholder, whether I'm working in a private or a public clinic, with the kits to be able to test and diagnose. So our cognizance of the problems you're dealing with will inform whether we are requesting for particular diagnostics or not. And if we request for them, then we're able to diagnose and actually treat the patient. So that is one of the key things that we can do as healthcare workers. Learn about the epidemiological patterns and disease prevalence patterns, 1. 2, the diagnosis, so that we can able to request for the diagnostics that we need. But that only happens when we have the differential that we are trying to see. Is it malaria or leishmania? Then we go with that. Then in the second question, is there cases patients with visceral leishmaniasis are not responding to the current regimens? Yes, there are certain cases that do happen, though I've not interacted with much of those. Most of the cases that I've seen is somebody started treatment, but there was sufficient medication, so the treatment had to be switched to an alternative. And as I mentioned, the first line of treatment currently we are talking about paromomycin, sodium stibogluconate for 17 days. If that doesn't work, or if we don't have sufficient supplies, we have to move to liposomal amphotericin, which would be up to 31 days of treatment. So those are the current challenges, but I've not seen any cases where the patient does not respond to treatment. Probably somebody from a clinical setting would be able to advise. Interventions for patients with hepatosplenomegaly. This is one of the greatest complications, but one of the key things that I noted even during that particular experience when I was at the facility is that the patients, when they were started responding to the treatment, actually the swelling of the spleen and the liver subsided over time. So there's no specific intervention for the swelling of these particular organs, but once you are eliminating the vectors and actually treating the patient, they're getting better and the swelling reduces. That is what I noted during that period. But probably there are other sources that I can also look up as well as we move forward. And basically you asked those questions, actually there's something that just come to mind is most of us, those who are in the healthcare setting, whether you're a student, you're doing your attachment, internship and all, your internship is an opportunity to gain experience and to take up leadership in terms of the problem that might be existing in your setting. So if you're able to do that, then you develop your own professional profile and see what interventions can you work and you open up your horizons in terms of what's possible. Thank you. I hope I've answered you, Mohammed. I see Nancy, you have a comment, please.
Yeah, thank you. Thank you, Dr. Obiambo, for that wonderful presentation. I just want to give a comment on the issue of how the question that was raised, how can you prevent misdiagnosis of these infections? I want to mention that actually we are facing a challenge with this because these diseases, we usually say that they are endemic in this and that regions. But we are realizing that there is emerging and re-emerging issues of these infections where you find them occurring in areas which were initially not mapped for the infections. So my advice to healthcare workers or the medics is that they need to get knowledge, the awareness that we are talking about. Because if you diagnose malaria, you discriminate a few of the diseases. If actually you have the knowledge of there is this disease that presents itself like this, then you are able to advise on what tests and also recommend on where these tests can be found. So we are getting these diseases because of climate change, like lymphatic filariasis. We used to say that it is confined in coastal regions. It is only because during mapping, it is only the region that was found to have high prevalence. But we are getting cases in other regions, like Busia. I found some cases and chronic stages of this disease in those areas. And actually the medics, some of them are not even aware. They are not aware. So let's raise awareness to our medical healthcare workers so that they don't misdiagnose somebody and do death. It would be so unfortunate. So thank you.
Thank you, Nancy. Thank you for that. And I think we have to be cognizant there are changes, and those changes can impact us substantially. And actually, just one thing that came to mind as you're saying that is the neglect is real. Because I remember there's a session that we had recently, and we had more than 50 people. But now when we're dealing with NTDs, we even have less of our colleagues. So that is another opportunity for us as young people. Can we create awareness on the importance of looking at how do we address NTDs among ourselves and among our colleagues? Because if we had 50 in one session and now we're having 12 or 15, it means the interest is not as much. And the interest is definitely not as much because people are like, what is in that particular area? What is happening in that space? Because of the neglect, lack of knowledge. So let's create awareness as much as we can as well. Yeah, over to you, Marion.
Okay, thank you very much for your presentations, Dr. Demba and Dr. Nancy. If we do not have any more questions, I think I'd like to urge you to register to our Youth Voices Network, where we can also be having such kind of discussions every now and again. And also just to advise you to create awareness. We are in this forum. Let us continue the discussions beyond this forum. Thank you so much for taking the time to join this workshop. I hope you have gained a lot. And once again, in case Dr. Nancy, if you have any closing remarks, and also I'll invite you, Dr. Dembo, if you have any closing remarks, you can issue them before we close the meeting.
Okay, I would just say thank you for the invitation for this platform. Actually, it creates like networking. And with this, it will push us further and lead to more awareness. So I think next time you'll engage more of people, more of experts, even in the control programs. Thank you, and have a nice time.
Thank you, that is noted. Any final remarks, Dr. Dem?
Thank you, Marion. Thank you. And thank you first. Thank you everyone for being part of the discussions. Thank you for being here and actually having an interest on how we can work together towards the eradication of NTDs. Thank you, Dr. Nancy, for honoring the invite and for being here to support and share your insights. And that is expert opinion, which we don't take it for granted. It's work that you've done for a period and you're sharing that information with us as young people to see how can we contribute to that conversation. So thank you so much for that. For me, what I would say is let's take the learnings that we've gotten from here, some of the challenges, the kind of thought-stimulating conversations. Let's talk about it. Let's ask ourselves among our peers, how do we change the narrative? That would be a good thing. Then beyond that, the next thing is let's work together. And in working together, I would urge you all, let's join the Youth Voices Network that we are establishing. Some of these challenging questions that we're asking, how do you play a role? How do you want to intervene? Do you have an idea of what project you'd want to run? Plug in and let's work on it together as we move forward. Thank you and have a good evening.
Thank you so much. I've sent the link in case you want to register for the Youth Voices Network. You can register through the link. I think now we have finalized the workshop / webinar. Thank you all and have a good evening.